I do want to sort of warn you ahead of time. I'm a fairly interactive speaker if you've not heard me speak yet. So my goal is to engage you in the learning experience. I got a chance to meet a lot of you and get an idea of where you practice. So there were a couple missing out of that group. We have a respiratory therapist in the back, and we have a PCA, or a patient care tech, with us as a part of it, as a part of that journey. So I thought I'd toss that in there. I do want to put forth my disclosures. It was mentioned about the subject matter expert. You're thinking, how can somebody be a subject matter expert in all of that? Literally, guys, what crosses all of that is fundamental nursing care, evidence-based fundamental nursing care. So that's how you end up having a level of expertise, because when you embody that, it ends up hitting pretty much all of the nurse-sensitive outcome indicators, which makes sense. Also, in the past, I have been sponsored by these various companies, but I wanted to share something with you. In 1991 at Henry Ford Hospital, I brought oral care into my entire facility. In 1993, I changed my beds and surfaces. In 1995, I went to basinless bathing. And all of that was done before any company ever sponsored me. So I think that's important for you to know from a conflict of interest perspective. So I'm teaching, you get objectives. The first one, some new strategies to identify risk injury, but I'm also going to push your thought process. Whenever I talk about fundamental nursing care, I've discovered that if we are not successful at hooking the value to these care practices and understanding where they sit in the nurses and the nursing assistants' role at a gut check level, then we're going to fail. I could dump all the evidence in the world on you, and it's not going to make a difference. That's part of the sustainability issue, is that we are challenged with people not really valuing it and seeing these practices as a bunch of tasks. And so we'll talk about some strategies on how to get over that. Secondly, we're really going to focus on various evidence-based strategies. A lot of you may be doing it, so I may be asking questions. How many have done this? How many have done that? So what I'd like you to do is almost mentally think about doing a gap analysis in your head as I talk, so that you can mark down what are you doing, what are you not doing, so that you have, when we get to the very end and look at designing a small test of change, you have an idea of what one you may want to do. Because I would like you to walk away from my time with you with a little piece of paper that has something by next Tuesday, well, maybe not next Tuesday, but within a week or 2 weeks that you could test out in your environment, whether it's a turn clock, whether it's a dressing, whether it's, you know, a different strategy for mobilizing somebody, but being able to test that out in your environment, or gathering more data if you need to. And I'm going to be talking about process change throughout the entire component of this, and how do you get over some of the barriers. One of the big ones, at least for the gang, and there's a bunch of ICU people here, patients too hemodynamically unstable for turning. I'm going to cover that one big time for you, so that you have literally a strategy to address it when you get back to your facilities. So let's start with that journey of how do we hook the value. How many have heard of the phrase, do no harm? Yeah, okay. IHI has it as their tagline. Our physician colleagues have it in their Hippocratic Oath. Here it is for nursing. Florence Nightingale wrote this on Notes on Hospitals. It may seem a strange principle to enunciate that the very first requirement in a hospital is to do the sick no harm. Yeah, pretty powerful when you think about it. So in my mind, there is no question that our advocacy role equals safety. However, I discovered something, so I'm gonna share that discovery with you. Are any of you working on sepsis? Yeah. If you're in an American hospital, you're working on sepsis, even in critical access. So the first guidelines came out in 2004. And the bundles followed. 2005, I started consulting with a hospital system in Northern California. And one of the things we talked about was embedding screening for early recognition. And in the triage area, we embedded it. We embedded it in the emergency room, ICU, and rapid response. But we did have med-surg nurses sitting on the committee. About 2007, and I've got to preface this by saying the docs were still messing with their order set. So they hadn't They hadn't agreed on an order set yet. And the med-surg nurses at the committee meeting said, we want to start screening. And I was a little concerned because there was no order set. So it would be a bunch of people out there having these conversations with not a whole lot of ability to follow through. And they said, no, we get that. But what that tool allows us to do is have more data to be able to advocate stronger for our patient. And I went, bingo, that's exactly what it does. And so we put it in, and they probably had the first med-surg screen in the country. But as a consultant, when stuff works, what do? You take the box and you move it over to the next place. And so I was talking about the importance of embedding screening into the nurse's shift assessment. And the facial and body language I got from the nurses in the audience were like, are you kidding me? Another group of check boxes you want me to do? And I'm thinking, okay, these guys got it over here. This was missing over here. And I started to think, why? I mean, literally, we now have data that shows that screen has the capability of reducing mortality in the wards or in the med-surg areas by early recognition. And so I probably should have done a qualitative study on this, but I just started asking nurses around the world to define their advocacy role for me. And what I got surprised me. It was very narrow. I push up the chain of command to make sure the right thing is happening for my patient. I coordinate and communicate to make sure the right thing is happening for my patient. And I also teach the patient and family how to care for themselves. There was not a single nurse in the world that said, I do my Braden risk score. I look at where the problems are and implement strategies to prevent somebody from getting a hole in their butt 3 days later. But isn't that do no harm? And by the way, delirium, falls, all of those validated risk screens, if we don't do them, harm occurs. But most nurses see it as a checkbox that they've got to do from a compliance perspective. Now, part of that's our fault, because it took Joint Commission in the early 90s to tell nursing to do their job. The other part of it as our fault is that we continue to keep it in the compliance bucket and fail to move it out of the compliance bucket and back into this is what you own as a professional registered nurse. And if you are going to use, or even a tech, if you are going to use, I'm a patient advocate, this is what it means. Way more powerful when you think about it. And part of the reason I think we see fragmentation, so I don't know if you guys are experiencing this as well. Now it's Caudy time, now it's Clapsy time, now it's happy, because it's not a HAP-U anymore, it's a HAP-E, but I don't think a pressure ulcer is happy. But they changed the language, so that's the way it goes. But these are all kind of in silos. And nursing is literally in the best place to holistically address it. So a perfect example of silo behavior is the IP world and the critical care world aggressively, and med-surg, aggressively yanking the Foley, which totally evidence-based. But the skin world over here may not be routinely measuring IAD and have as aggressive of a program. And we now have data that shows you develop IAD, you get a 5 times higher risk for a pressure injury. But if the two are not playing in the sandbox together, harm can occur either on this side or this side. And so I really think we are in a perfect place to be able to move this agenda forward in terms of a holistic strategy. So when we look at what it takes to prevent bad things from happening to humans on my watch, what I'm going to share with you is a broadened definition of hygiene and mobility. Now, I got to tell you, I've been a critical care nurse for 37 years. Those are not sexy practices. And I found out from my med-surg nurses, they don't consider them sexy either. It's got to compete with the latest chemotherapeutic agent, the newest cardiovascular drug, the latest machine that's come out. And so I worked to try and create a little competition by creating a term called interventional patient hygiene. You gotta work it, you know, to get people excited about something. And so, but in all seriousness, guys, the definition of hygiene in the dictionary is the science and practice of the establishment and maintenance of health. Does it get any more fundamental than that? So when you put an action verb in front of it to intervene, what it says is I am proactively intervening with evidence-based hygiene and mobility strategies to eradicate 3 of the top 4 errors in this country: healthcare-acquired infections, falls, and pressure injuries. That is so much more powerful than a butt wipe program over here, a hand hygiene program over here, a yank the Foley over here, a clean the mouth over here, but collectively putting it together. And so I'm a pictorial learner, and by the way, this is all published, so you'll have the reference for it. But patient in the center, you can also put the patient and family in the center. Hand hygiene around. The blue is fundamental nursing care activity that does not require a physician's order, and the red is the nurse-sensitive outcome indicator. So when I look at it, oral care and mobility, I have the capability of impacting vent pneumonia and non-vent pneumonia. How many of you know non-vent pneumonia is the #1 infection, tied for the #1 infection in the country? Because we cleaned the mouths of the vented patients and we forgot everybody else's mouth. And we just sort of let the crispy critters run, if you think about it. So we have that impact. Catheter care. When was the last time somebody watched you put a catheter in? If you've been part of the new science movement, somebody has watched you. But prior to that, it was 37 years. How well do you think I do that? Somebody should be watching me to check me off from a competency base. Am I part of an aggressive removal program? How do I manage incontinence care? On the central line, am I present when it's inserted? What is my role in that? And how do I address that? How do I deal with dressings? And are they not occlusive? And how do I access the site for CAUTI and CLAPSI? But probably the biggest bang for the buck is how we take care of the skin, because it is the largest organ to prevent against infection, and how we bathe them and how we mobilize patients. Because that literally can impact CAUTI, CLAPSI, surgical site infections, falls. And by the way, I no longer call it pressure injury prevention. I call it eliminating hospital-acquired skin injuries. And the reason is, the minute I say the word pressure, where does your head go? To the butt and offloading. It doesn't bring in the moisture. It doesn't bring in devices. It doesn't bring in tears. It doesn't bring in shear. And so a larger kind of look at it. Now, one of my favorite things, I was sharing this last night at dinner, it was an organization. How many have skin champions? I know this group over here brought a bunch of theirs. Okay, so you have the skin champion model. So I can't remember where this was, but they created a different name for them. They called them the Dermal Defense Team. Isn't that cool? I just love that. I mean, I'm on the Dermal Defense Team. So instead of a pup team or something like that that focuses just on the pressure, this is about keeping the skin as a defense. So I thought it was pretty powerful. So the other component that goes with this, may I ask, do any of you round? I know a lot of the WOCs, and people in leadership and people in safety are auditing. And that, okay, so may I ask, what does the nurse look like when you come up with that piece of paper? Exactly, or ducks, they scatter like roaches. No, however, it's because it's a checklist, and we have reinforced that kind of checklist behavior. So I would ask you to step out of your comfort zone and do something different. And by the way, the first time you do this, they will look at you like you got 3 heads. Seriously. And that is, and I would even ask the WOCs, because most of them are nurses. I think you have to be a nurse, right? So you can round beyond the skin. You can see if a dressing is occlusive or not. We need to be more holistic in our rounding. And what I would like to see is coming up to the nurse and go, how are we going to prevent harm in this patient today? and they look at you funny, and you literally take the opportunity to go, well, part of your advocacy role is to do no harm. So one, it allows you to connect the value, because everybody values that title of patient advocate. And then that do no harm question forces them to start critically thinking and not thinking about the tasks, but thinking about where the harm can be. And then we talk about, well, how can we prevent that harm? What are we doing from an evidence-based perspective to prevent that harm? That is such a more powerful rounding process than I'm coming in and going, is the bag off the floor, or have they been turned, have they done all of these various, and by the way, I am pushing out to IPs to round that way. So they're not just rounding on infection, they're also rounding on skin. And global safety people rounding on the entire body instead of just these squares, because we have created this in the end user by the way we reinforce that behavior. So a way to think about it. So the other component, and I've got it a little later, which I'll talk to you about, and that is sustainable change, and we'll discuss that. But what I've discovered as to why we end in these silos is the fact that how many of your organizations, the culture of safety is really focused on the patient, and you don't really hear about caregiver safety? In the same sentence, it's almost all focused on the patient. But what I gotta tell you is if we don't dual it, we're never gonna succeed at this, especially around movement. Because if we are not addressing caregiver safety on in-bed and out-of-bed mobility, we're not gonna effectively achieve it as part of that journey. So when we look, I'd like to change that paradigm. So it's a safety culture for both the patient and the healthcare worker in combination. And so part of your role is being a part of this journey that when things are being talked about that have to do with mobility and skin, you make sure the right people are there, that your safe patient handling people are there, and that we integrate this. Safety for the patient and healthcare worker are integrated. So what it does is we don't have a falls program over here. We don't have a pressure injury prevention program, safe handling, and a patient mobility. We may still have general focus, but there is a way that those come together because they all intersect. And when they hang out in silos, we get wrong answers. So let me give you a wrong answer. All right, in the critical care, who's my critical care nurses? Okay, so do you guys have ceiling lifts? Yeah. So how well are they working to move somebody 2 inches up in bed? How many nurses are hooking up 8 rings to move somebody 2 inches in bed? Well done. But mostly 80, 90% are not doing it because nobody looked at their workflow. Nobody did time studies to determine the efficacy of ceiling lifts for in-bed mobility to actually achieve the practice, but also protect the caregiver. Now, in my perfect world, because that's where I live, I'm gonna work real hard to get all of you to hang out in my perfect world, where I want ceiling lifts is I want a hook at the end of the bed so that I can walk my ventilator patient without disconnecting the vent, and they're safe. They're hooked up into a jumper or a jacket. I want a track going to the toilet. I want a track going out into the hallway, and I want a track around the entire nurse's station because I want to hook them up. Because a gait belt ambulation is a controlled fall. So, by the way, there's a rehab hospital in Chicago that has that. I have to get there. But I think in new design, that's what we really need to look at if we are truly moving to full mobilization. But if we don't play together, it makes it significantly difficult. So when we look at high reliability organizations, Leadership is engaged. Culture of safety means both. Our organizational processes and infrastructure support safe practice for the patient and the caregiver as a part of it. And we implement strategies collectively, and we measure strategies collectively. We got to get out of our own silos. You know, we talk about the silo of budgets, materials management, pharmacy, and labor, and how much that's causing a challenge to us advocating for the right thing for our patients. We have to get out of the silo to make sure that we deliver the best care with those outcomes. And to that event, we've been presenting this nationally, this concept that these four are never apart from each other. Because there's now data that patient progressive mobility reduces skin injury if done correctly. It also reduces falls because the patient's conditioned better. And if it's done correctly, we don't have increased injury by the staff. So it's really this collective concept of ownership. And what is exciting is when any of these are talked about, you have the capability of raising your hand going, hey, we need these souls at the table too. That's what it means to be a part of this journey. So how well are we doing in these? Well, in terms of early progressive mobility, nobody look at your handouts if you printed your handouts out. All right, so my med-surg nurses, do you believe that the ICU nurses should be able to achieve Q2 hour turning with their staffing ratio? Yeah. Okay, so I didn't mean to set you up. I'm an ICU nurse, so I'm setting myself up. So there was a study done, mixed med-surg ICU in the United States, 566 hours of observation over an 8-hour period every 15 minutes to determine the percentage of which patients got turned. Q2 hours. So what percentage of patients got turned Q2 hours? 2.7%. What percentage of patients never moved in a 6 to 8 hour period? 50%. We have a problem, guys. There's a value structure component to this. Not just, there's also a resource. How many are still using pillows? Yeah, how well is that working? I mean, literally, we used them with Florence Nightingale in the Crimean War. They were stuffed with straw. Now they're stuffed with crappy foam. And our patients are bigger. And so it's like even if you do a turn, they don't offload anything because they smash back into it. Who is really good at curling pillows? Tuck, tuck, tuck. But now we want people to be more awake and moving and not sedated. I look perfect in bed. So that pillow moves. It literally goes boing on the floor. And so the concept is again, thinking up these different solutions to make it happen. Now, the reason why I can say there's a value structure component to this is there was a more recent study done in the UK in their ICUs. So by the way, they have about 12-bed unit, one-to-one nursing. They run their own vents. They also have a dedicated chest physio. So you would think you would be successful at achieving a Q2 turn. So they measured it slightly different. They measured it hours between turns. So they did a 2-day 40 ICU positioning prevalence study. So what do you think the hours between turns were? 5 hours with a standard deviation of 3. Some was 8, some was 2. Clearly, not good stuff. So there is a value component to this. And I actually have an hour-and-a-half talk on this, but you're going to get the short version. How many remember the Institute for Medicine report? It was the late 90s. I like to call it the national cattle prod for our safety movement. That's the one that came out and basically said the top 4 errors in the country are medications, infections, falls, and pressure injuries. Whose domain do all 4 of those sit in? So how did nursing end up owning the top 4 errors in the world, by the way? This is a worldwide phenomena. It's not just here in the States. So I do have a long talk on it, but you're going to get the short version. So who practiced prior to 1990? Actually, even prior to 2005. Okay. If you were in a frontline role, did you know when you make a med error? Yeah, you still do, right? Do you know when you don't follow a doctor's order? Yeah, that gets pointed out pretty well. Prior to 2005, did you know your unit-based CAUTI rate? Unit-based fall rate? Pressure injury rate? No. So, do you guys all remember B.F. Skinner? Behavior that is reinforced continues. Behavior that isn't doesn't. So literally, there was no reward, recognition, or reprimand structure for the presence or absence of fundamental nursing care. So it disappeared, the value of it. And so therefore the practice disappeared. And if we don't put the value back in and we just put the technical, you're going to get a Band-Aid. And what happens to Band-Aids? They fall off. So how do you put that value back in? I have no clue what your orientations look like. Not a clue. But I would suspect the wound care nurse comes when they can, the infection preventionist comes when they can, the risk manager quality person comes when they can. It's sort of this kind of I would ask you to think about redesigning it so that the first introduction they get is this discussion of advocacy and what that means. Then each of the courses are care of the patient at risk for skin injury. The WOC still gives it, but it's designed as care of the patient at risk for, care of the patient at risk for pneumonia, care of the patient at risk for device infections. You know, so you could literally, and then, by the way, some or all of these will be used to measure the quality of nursing care you deliver in your unit, wherever you're going. Now, the next step, and I haven't really gotten people to this step yet, is those nurse-sensitive outcome indicators should be in the frontline nurse's performance appraisal, because nursing's a team sport. So if I see a clock up there and it says they should be on the right side and I'm given a report and they're flat, what is my role as an advocate? Help me. So I'm getting a report, help me to understand why this patient is flat instead of on the right side, because there's potential harm occurring. We literally have to start using that language if we're going to put the value and that connection back. And in my perfect world, I would create that program as the first nursing program, first course every nurse took in the world, that they would be introduced to this is what you own as a professional registered nurse. So those are the studies so that you have them. How are we doing from an environmental scan on early mobility practices? So this was a study published in 2015, 687 randomly selected ICUs, because the early mobility movement started in the ICUs. Hopefully the ICUs understand that if you just do it in the ICU and you don't connect it to the floor, the patient goes to the floor and bounces back to you because they didn't move, because we have movement issues in the med-surg environment as well. 51% academic affiliation, mixed med-surg was mostly the ICU. 34% had a dedicated PT, so that's a movement that's starting to happen in the United States. And what I was excited about, 52% of it began it on admission. Now, here's the data. There's about 47% that said they're doing early mobility practice, but only about 28% of them had a protocol. So how much do you really think early mobility is happening without a protocol? I can tell you it doesn't. And then over here, no early mobility practice at all. People are considering it, so that's about 40%. And then about 12%, it never even crossed their blood-brain barrier to think about it. So that sort of gives you an idea where we're at with that. However, I want you to take a look at the outcomes of early mobility programs. And you can see skin injury is one of them. Reduce the days in delirium or increase delirium-free days. And that affects both short and long-term outcomes for the patient as a part of this. So I have a question to ask. If there was a pharmaceutical agent that gave you all these outcomes, how many patients in the hospital would be on that pill? So therefore, everybody in the hospital should be on a mobility protocol. Make sense? And all I hear is, well, PT didn't come and evaluate them. Go back to Notes on Nursing from Florence Nightingale, and it'll literally say mobilization, nursing. So don't worry, though, if at first you don't succeed, you're running about average. Because we're all facing the same challenges around the country and actually around the world, because I was just over in Australia giving early mobility workshops. Same challenges. What about the data around pressure injury? You guys probably know this better than I. It is the fourth leading error. About 2.5 million patients are treated annually in acute care. The last NDNQI database that I saw, so it wasn't done in the percentages that you do here in Minnesota. It was critical care around 7% and med surg around 1 to 3.3%. Have any of you ever participated in Hillrom's pressure injury survey? My entire career, the combined pressure injury rate hung around 9 to 11%. In 2011, it was down to 4.5%. So we are collectively making a difference. But I will tell you, you guys need to be proud of yourselves because Minnesota is leading the charge on this. The most severe are sacrum and heels. That's, I would say you don't have as much of a heel problem. You have more of the sacrum issue. But what does that tell me people are hanging out? What position are they hanging out in? Supine, but with the head of the bed at 30 degrees. Yeah, so, and if you want to put in here, I think it's important what it's costing, 9 to 11 billion. Cost of individual patient care ranges between 20 and 115,000, and that's if you need a flap, you know, and you go the full court press. And then 17,000 lawsuits are related to pressure ulcers annually in acute care. So I'm not talking even long-term care. This is in acute care. About 60,000 patients die from a complication related to a pressure injury. So how many of you are aware that Superman literally died from his pressure injury? Yeah, got septic from it and arrested. So now, how many are aware of the definition changes? Okay, that we've moved to injury. And it makes, I mean, simple, I'm not going through it, but it makes sense. However, I heard that there was some debate about the concern of the use of the word injury because of lawyers. Totally American, isn't it? But ulcer denotes an open area, and deep tissue injury is an open, and either is category or stage 1. And so it makes sense, and I was glad that the National Pressure Ulcer Advisory Panel, you know, and that whole group made the decision to go to injury because it makes a lot of sense as a part of it. This is the other thing we're dealing with in the moisture world, and it does now have a name, and it's had a name for a while. The overarching term is moisture-associated dermatitis, and then there's bifurcations. For me, I'm a simplist. So we have moisture-associated dermatitis, anything that is not caused by urine or stool. But that is moisture. And then we have incontinence-associated dermatitis, which is contributed by the urine and stool. So the MAD, you're talking about breast tissue, pannus, and those areas. So what do you guys do for that moisture? Interdry is probably the most effective at this point. What if you don't have interdry? What are people doing? Do you still see people stuffing pillowcases? Yeah. So, by the way, if you don't have interdry, the best thing you could do is clean it, moisture barrier it, and stuff a half wick-away pad, because you all got the new wick-away pads, right? The incontinence wick-away pads. It'll suck the moisture. Because interdry has silver and it also has a wicking away. So those are the two purposes. You're not going to get the silver, but the reason why yeast forms under there is the moisture. And so if we can get rid of the moisture, so no pillowcases, no gauze, you got to use something that wicks as a part of it. So we know that this is a top-down injury and that the skin breaks. The skin is more fragile and you have a higher risk for a pressure injury as a result of incontinence-associated dermatitis. So there were a couple epidemiological studies that were done recently. They have not been published yet in peer-reviewed journals, but they have been presented nationally. And literally measuring incontinent rates between 41 and 53%. Give you an idea. And in this particular one, 24% IAD rate, and 73% of it was facility acquired. And in the ICU, the IAD rate was 36%, so significantly higher. And they were also able to show that if you developed IAD, you had a 5 times higher risk of a pressure injury. So my next question to follow is, how many of you are routinely measuring IAD when you do your pressure injury measurements? Well done. That needs to be universally adopted. Because I got to tell you something, if you're looking at these pressure injuries and you're only measuring pressure and you're not looking at the other risk factors, you're going to miss the boat, because you're not going to design programs, aggressive programs, to address it. And I walked into a unit, and it's all published, so they let me share it. I walked into a unit in 1990 at Henry Ford Hospital, the MICU. We had a 26% incident rate for pressure injuries. And by the way, back then, critical care was between 15 and 40%. But it drove me nuts. And literally, I hired in October. I did my first pressure injury prevalence, and I evaluated moisture. There was no term IAD, but I evaluated moisture. 60% of my injuries initiated with moisture. 40% were pressure. And if I had not separated those, I wouldn't have targeted my 2 strategies to address moisture and to address pressure. So it's really critical that that is included in your world. So this is your data, but I think it's important for you guys to see. So by the way, this kind of sawtooth basically says you don't have a stabilization in your practice. Sorry. No problem. However, look at the margin. In terms of you're trying to go from 0.364 to 0.29. That's a 20% reduction because of how good you guys have already done. So I think that's important to take into account. Make sense? And when you look at your PSI 30, you guys have already gone below the 20% reduction of where you're sitting as a state. So clap for yourselves. I know it seems silly, but I got to tell you, that's another thing that we don't do well in nursing, is the celebration. We sort of go, okay, we got that one, let's move to the next problem. Instead of stopping and going, wow, and really taking in the impact that you have had. So as you heard, adverse health events in Minnesota that's the work. Here is the pressure injury, so it's sort of been stagnant kind of thing, but lower than the national. I will definitely tell you that. And as you can see, the dark blue is ICU, so a lot of it is ICU. I will say the med-surg still has a significant number. And so one of the things in the data that you guys collect, do you put how many of those patients had an OR procedure? Okay. In your own data, you guys should be collecting, making sure that is in there.
Yeah, we do collect that.
Okay, because that's important as a part of that journey. And as you can see, coccyx is still your largest. And Lori presented some of this data. And so so this one right here is your face. So that sort of tells you face and, I think it's hard to tell between the face and the ear. Is that face? I think so, yeah. And this gives you an idea of your device-related pressure injury rate. So we are still not making a dent in that. So let's look at caregiver harm. All right. 8 out of 10 nurses are working with some musculoskeletal pain. Let's see if you hit the statistics. How many of you are currently experiencing some form of musculoskeletal pain that you believe is related to your job? Please raise your hand. Okay, so pretty much, yeah, pretty much like the research. So the next question is, how many of you reported it? Congratulations. Got to report it, guys. Because if you're not reporting it, then the caregiver safety handling gang doesn't have enough ammunition to be able to show the cost-benefit analysis. And literally where a lot of the harm occurs is in repetition of motion. So my youngies here think, oh, 100 pounds, that's lightweight. And it's this repetition of motion, and then at one point it's like, and your career's done. So it's important that we all pay attention to this. Nursing assistants, number 2 in the country for all musculoskeletal injuries. Nurses are number 6. And we also have obesity issues, so the patients are bigger. So if we don't have the right tools to make this happen, we can harm ourselves as well. Also, there's a shortage. They're going to be facing a shortage of us because there's a boatload of us that are going to be booking out of the system. Now, the challenge is we really don't have a shortage of people that want to go into nursing. We have a shortage of faculty. There are waiting lists at most nursing schools. And we have a shortage of faculty. You'll get my commentary on this because they don't pay them enough, which they need to change. However, this is what cracks me up the most. We in healthcare think 100 pounds is light. How many of you have the new garbage cans in your neighborhood? So we have done a better job of taking care of our garbage workers in safe handling than we have with our own clinicians. That's got to change. On average, nurses lift about 1.8 tons in a day per shift. So how long have we had a safe patient handling movement in this country? Anybody know? Safe patient handling movement. It's been about 10, 12 years when the VA kicked it in the mid-2000s. So the question is, how well are we doing? I always use data. I have a favorite saying, in God we trust, everybody else must bring data. So the concept would be, take a look. So this is, by the way, per 10,000 full-time equivalent employees. 2003, 10,000, 6 days off of work. 2009, 8,700, 8 days off of work. 9,200, 6 days off of work. 10,000, 8 days off of work. 9,900, 8 days off of work. 9,800, 7 days. 9,800, 9 days. And by the way, nursing assistants, you're at about 18,000. With about 5 days off of work. Has the data changed? So if we continue to do what we're doing, are we going to be successful? Not likely. And so that means we've got to take a look at what we can do to effectively achieve outcomes. And the last one in this journey, now, by the way, I wanted to give you this full concept. I am going to be focusing specifically on skin as a part of it, but addressing those issues altogether. So from a falls perspective, it is one of the leading cause of hospital-acquired injury. Between 700,000 and 1 million patients suffer a fall. 30 to 35% of the patients sustain an injury, and I would say some of that occurs during ambulation, during mobility. Some of it occurs related to getting up, having a catheter in, and tripping over the catheter. I mean, there's all sorts of concepts around it, and it has been identified as a major issue. So when we put it all together, it's got the caregiver risk on this side. It's got the patient risk on this side for immobility and skin risk. And then it's got what is the science telling us overall that we should do? And when we do it, what are the risks for the caregiver? So this is a tool that puts sort of all 4 of those together as a way to target and make sure that we're addressing risk factors on the patient and caregiver side as we implement the strategies that benefit prevention. So here's that concept of how to drive change. Gap analysis. So how many have started ticking things in their head? Yeah. Build the will. That's what I'm doing here. I'm building the will through the science of what the problem is. Protocol development. You guys you're launching your injury bundle to help with sustainability. You've had Safe Skin. Was that the original? Yeah, that was the original program. And you made it pretty prescriptive to say, you know, these are where the risks are. This is what we have to pay attention to as a part of that. Because when we put structure and process together, we end up with effective outcomes. So, gap analysis. How do we assess risk? How do we do pressure injury turn shear reduction with caregiver injury reduction? How do we achieve that early mobility? Because guys, if we can't even turn somebody in a bed, what's the likelihood we're going to walk them? Yeah, exactly, 0 to none. Also, device-related injuries and managing incontinence and other moisture-related injuries. So this is sort of the mental gap analysis that I want you to think about. So, and we are going to discuss hemodynamic instability. So how do we identify patients at high risk? What do we use? Braden, right? Yeah, you just sort of can't do a Beavis and Butthead flyby, look at their butts and expect that you're going to get a good assessment. You won't have this in your handout because one likes to keep, you know, these little surprises every once in a while in their talks. However, we do know Braden is a reliable and valid risk tool. We know your own clinical decision by itself is not enough. So that's important. But I think we really need to look at the Braden through a different set of eyes. And my understanding is the majority of this is happening in Minnesota, which is exciting to hear that a lot of you are looking at subscales. So this was actually a study done out of the Mayo Clinic, a retrospective cohort analysis of 12,500 patients in progressive and ICU settings. It was in 2007. They identified patients that had a facility-acquired stage 2 through 4. And then they went back and got the initial Braden, the initial subscores. Did this patient have acute respiratory failure? Did they have did they have a surgical procedure? And did they have renal failure? And they calculated time to event and the number of pressure injuries. So by the way, kudos to these guys that their rate was 3.3% in 2007. But I also think the Mayo Clinic has more money than God. Does anybody work there? They used to have more money than God. I don't know if it's changed, but good practice. Braden, the total Braden score was predictive at a correlation of 0.71. The subscales correlated at a 0.83. So much stronger. So which subscales were independently predictive of breakdown? Because by the way, when I read this article, I didn't read the abstract because I wanted to see if I could guess it. Moisture, yes, it's about 50%. Mobility, no. And I thought it was mobility. It's friction shear. If you have a friction shear score of 1, you have 126 times the risk for the development. So by the way, anybody you're dragging up in bed because you're not lifting them because they're too heavy, you are literally in the category of 1. And moisture was about 50% of that. So if you had a 1 or a 2 in the moisture subscale, you ran an independent risk as a part of it. And when they put it all together in this multimodal, included the subscales, surgery, and acute respiratory failure, they could predict at a 0.91 who was going to break down. That's pretty big correlation. So how many are using subscales within their EMR to drive interventions? If you don't, by the way, your buds, there's a bunch of them here that, how many are using Epic? Epic, by the way, they have. What I would recommend, and I think you shared this with me last night, is competition with your IT people. Say, hey, the hospital down the street did this. But I think the CNOs and CEOs of our hospital systems need to push Epic to create this module because it's been created. Todd Brindle did it for VCU. You guys have done it here, so it is out there. So the concept of every hospital having to recreate this is just nuts. But we got to push them because it's driven by money, because everything's driven by money as a part of it. Now, there is an IAD assessment tool that was done by Joan Junkin. You can slim this down, but it's a valid tool that was used, and so it's a way to assess, along with your pressure injuries, to end up understanding what your IAD rate is as a part of it. So I have this kind of quote as a way to get your mind to think. One mind's once stretched by a new idea never regains its original dimension. So what message am I sending? Don't use the total Braden score. Use the subscales, because the total Braden score has become so homogenized that it doesn't really direct nurses to the interventions as a part of it. So when we look at all of this, let's start driving on the skin side. How are we doing? I'm just making sure. Oh, we're doing good. All right, so let's talk about two of the major areas that create a challenge, sacrum and heels. Now, have you all seen the Bible? It's the Skin Bible. 2014, all three international groups participated, the Pan-Pacific, the European, and the National Pressure Ulcer Advisory Panel, to come up with guidelines. Now, I will tell you, in 2009, when two of the groups came up with guidelines, they removed two-hour turning. They said turn the patient as frequent as the patient needs it based on their clinical situation and the surface that they're on. However, I'm also a disciple of plan, do, check, act, and process variation. The likelihood, so how many nurses do you have working at your place? 3,000? Are you a big place? Yeah. So 3,000 nurses, 500 a day maybe, 300 a day, each making their own positioning schedule based on the surface the patient is on and the condition the patient's in. How's that going to work? That would be a no. It's not going to work. So hence, that's why you still see Q2. And I will stretch it at night, but I will only stretch it at night if you have a sleep protocol, so that it's protocolized in order to get blocks of REM sleep, 90 minutes at a shot. And usually you have to put a half hour before and after that. So my goal as a midnight nurse was literally to achieve the maximum 3 REM cycles for a patient, the minimum at least 2. And so therefore that would adjust the positioning schedule. This was a study published in 2015, and we have some more as well. Cushioning devices to maintain alignment and 30-degree turn. What the data showed is pillows don't do that, and they don't hold it after an hour, and I've got another study to show you. Wedges do, but there's research that shows wedges can be hard. So not all wedges are made alike. And so you have to pay attention to it. How many are using wedges? Okay. So by the way, do you have a big long one? Good. Because the big long one, when you put it on humans, it literally sits right on the sacrum. So you really want 2 going from here to the middle of the back, iliac crest and down, so you literally have offloading of this area, and hopefully you can stick your hand in and do an assessment. Because that's my perfect world, is that whatever you're using allows a very quick assessment that you have true offload, because that's what the science supports as well in that journey. So how many learned about mitered corners? Yeah. Ooh. Everything needs to look beautiful. And by the way, if you work in ICU, and I also found the med surges this way, I'm not a good nurse unless the patient looks perfect in bed. And if the arm goes over here, I need it right back over here. Okay, so 1, we got to get rid of that. The second is, how many are using fitted sheets? Okay, you got to pay attention to this. Even the stretchy fitted sheets shrink. However, it drives nurses nuts to have a messy bed. However, when you put a fitted sheet on that has shrunk, and you have an immersion mattress, immersion and envelopment mattress, you just messed with your very expensive surface. And it is the same thing with layers on the bed. We grew up with double bed rolls for code browners and GI bleeders, you know, to where you would just roll it off and the made bed would be directly underneath it. And that was about 7, 8 layers. There's research that literally shows you get more than 4. You have an independent risk factor. And so one of the things is trying to control that from that perspective. Also, prophylactic dressings. How many are using prophylactic dressings? So 2 good meta-analysis, both for looking at the nasal bridge and also evaluated for sacral pressure ulcers. If you're not familiar with reading this is what's called a confidence interval line. Everything on this side favors not using it. Everything on this side favors use of it. And the diamond is sort of the final. If it crosses the line, it's not statistically significant. And the further away from the line it is, the greater the statistical significance. And so we actually had a great discussion before the journey started with my buds in the back over there about the 80-20 rule. So when you have non-invasive mask ventilation, and you're using the nasal bridge, no matter how long or short that ventilation is, it should be protected automatically. That should just be the standard. Even though some may only have it for 3 hours, it is worth the 80-20 rule because 80% of them are going to have it long enough to where they're at risk for a pressure injury. That little 10 or 15%, I'll pay for that dressing. I'll pay for it by preventing other strategies. So that sort of gives you an idea. Now, I will tell you, in my perfect world, the challenge I have with the sacrum in a practicing environment, so I'm talking inpatient, I'm not talking OR, I'm not talking when they go to interventional radiology, you know, when they go to, or the emergency room. But in practice, it's very difficult to see the sacrum because it's covered. Then you peel it off and you try to put it back on, and it doesn't stay, it rolls. So for me, I'm looking for a more permanent solution for addressing shear and offloading pressure that can be part of the bed. And so I see the use, I see the value, the science is there. If you don't have any other options, then yes, this is what you want to do in the sacrum. But there are other options. So when we look at how do we move people, so how many have disposable slide sheets that have to go in and out, off the bed? Okay, by the way, not going to work. Anything you have to take on and off the bed is not going to work because it'll go on once, it'll go off, and it'll find its way into some equipment room in the back. So it's just not easy. And as a result, that impacts it. Also, interesting enough, on these specialty beds, and now even integrated into people's regular bed, is the ability of something called a turn and assist, where you can blow it up. I can't believe people don't use it. It's literally 4% of the population, when I get a national audience, that uses that to help facilitate. Now, part of the problem is if you're stuffing pillows, the pillows don't stay, and so that's why people don't use it. But I think it would stay if you were using wedges. Lift devices, we already had that discussion as a part of it. Breathable glide sheets that can stay on the bed. How many are using those? That's really where the science, from my perspective, and we'll talk about that. However, at national meetings, the last one was probably 5 months ago or 4 months ago, 60% of the people were still using draw sheets and pillows. We're not going to fix caregiver injury. We're not going to fix true offloading when we're doing something that's been done forever and shown not to work. So that sort of gets you to this consulting model or this concept. If I just go after you with the attitude and accountability, here you must do, and I have not connected the value, it's the wrong way to go about it. And actually, that's what happened right after the IOM report. Most of the chief nursing officers wagged the finger and said, this is fundamental nursing care. You ought to know how to do it, so go forth and conquer, and then we're going to audit the bejeebies out of you and knock you over the head. And how well did that work? Yeah, it didn't work. So putting the value in and then teaching the skill and knowledge, that's a critical component. But if I only do that, I've got people that know what to do, value it, but may not be able to achieve it because they don't have the right resource and system. So I'm going to give you some examples. Remember I told you non-vet pneumonia, tied for surgical site infection? Most med-surg units, all they have to clean the mouth is a toothbrush that I would only use on the grout in my shower and toothpaste that has zero therapeutic benefit whatsoever, Fresh Mint or Sparkle Fresh. No way I'm going to tackle the germs in the mouth with that. That's a resource and system. We fixed it in the ICU. We need to fix it in the med-surg. Another example, what is the likelihood that you're going to sing Row, Row, Row Your Boat every time you access a port on a line? 0. It just doesn't happen. Technology, cap, a visual that it tells you it's on there and it's been clean. The system is it hangs right on the IV pole. The other system is you don't just put it on central lines, you put it on peripheral. So the nurse doesn't have to go, is this central, is this peripheral? Which one should I use a cap with, which one should I not? Because too much variation. They're faced with that day in and day out. So does that make sense? So a better system, in my mind, is a breathable glide sheet that stays. I have foam wedges. The whole thing breathes so that whatever expensive bed and mattress system I'm using, they immerse into, so they benefit from that mattress. Reduce layers of linen, so I want to force function layers of linen. Flat sheet, slide and glide, and a wick-away pad. That's 3. If I find anything else on the bed, no, only kidding. And a wick-away pad, and I want it to protect the caregiver. So when I'm looking at systems, that's what I'm looking for. I'm looking for an integration of those and actually help me achieve the mobility. So I'm really taking all 3 of them, not falls, but all 3 of them into account for in-bed mobility. So this was a study published in 2016. It was a non-randomized study, comparative design, in a neuro-intensive care unit. And literally they had 11 beds on this side of the door and 11 beds on this side of the door. So one side of the unit continued with the draw sheet pillow, and the other side used a turn and position system. And they studied pressure incidence, turning effectiveness, and nursing resources. Because it was a non-randomized, I did include the demographics here so that you could see there was no statistical significance between the 2 groups. Nurse satisfaction, 87% with the turn and position system. 34% with the old way. So if something has 87% satisfaction, are the nurses going to use it? Yeah, exactly. They were able to successfully achieve the 30-degree turn and maintain it beyond an hour, where pillows got nowhere near that, 15 degrees, and didn't get anywhere near an hour. There were 6 pressure ulcers in the standard of care group that developed. There was 1 in the positioning system group. That was within 24 hours, and it was a deep tissue injury, so they believe it was probably not related. But in a research study, you have to report everything. But number of times pulled up in bed was significantly less, and less resources needed to mobilize somebody. This was a prospective QI done, 1 surgical ICU, 1 medical ICU, 2 phases, the standard. By the way, they had a standard low air loss. Interventional was a turn and position system, the large wick-away pad, and the foam wedges, and they were all part of a single product. The inclusion criteria were newly admitted, non-ambulatory, requiring 2 or more to assist with turning and repositioning. Turning procedures were timed, admitting till discharge. No difference in socio-demographic or clinical data between the 2 groups. In the first group, phase 1, there was 28% stage 2 pressure injury rate. In the second group, 0. And time to turn In the first group, 16 minutes between 4 and 60. So they did an observational timing on this, which I loved. I was like, because how many go, can you help me turn? Can you help me? I mean, that's where some of the, yes, that's where some of the 30, and the average time on this device was 3.58 minutes with a standard deviation between 1 and 8. So it was also more efficient. And when you look at a combination of caregiver injury and prevention, this was did a comparative over a fairly decent length of time. So they had a baseline data for a year, and then they had an implementation period from 2012 to 2015. And so there were 3,660 patients in this, so it's a fairly decent size. They compared pressure injury rates, patient handling injury, and cost. So they had a 48% reduction in their pressure injuries, and they had a 74% reduction in their caregiver injuries. So when you put the financials together for both of those, you've got some big money saving as a part of it.